Systemic response to injury. This guy got hit by a car. Either he dies instantly or stays alive with injury. Mild to moderate injury, his body will recover. Without support he may not survive, especially in severe injury. In the following slides we will know how his systems will act after trauma to recover him and how we help such patients. Specific learning outcomes. Define homeostasis and its relation to systemic response to injury. Determine factors that responsible about variability of response. Demonstrate understanding of the purpose of response to injury. List the factors responsible for systemic responses. Discuss each type of response to injury. Differentiate between infection, systemic inflammatory response syndrome, sepsis, severe sepsis, and septic shock. Homeostasis. Body systems act to maintain internal constancy. Homeostasis is maintained by coordinated response of all systems to environmental changes, internal-external, to return to normal physiological status and to promote healing. Systemic response to injury is a mechanism of homeostasis. Systemic response to injury is maintained by coordinated neuroimmunoendocrine response. How the SRI return the body to the status before injury. The constellation of neuroimmunoendocrine changes following injury acts to provide essential substrates for survival, postpone anabolism, and optimize host defense. What is the mechanism? Detectors within the body, such as peripheral nerves for pain, baroreceptors for blood pressure changes, and innate immunity for foreign bodies, send their responses to a processor. Examples of these processors include the cerebral cortex, hypothalamus, and cranial nerves. This processor then transmits signals to an effector like the autonomic nervous system, adrenal glands, and pancreas, which subsequently carries out a specific action in the body. This classical homeostatic process operates through a negative feedback loop, otherwise they become harmful. These concepts pertain to mild to moderate damage and normal physiological function. They fail to account for the progression of disease following severe injury or sepsis, nor do they consider patients who would have succumbed without contemporary mechanical organ support. Such patients often demonstrate characteristics of an open-loop system, which can only revert to classical homeostasis once the primary abnormality is medically or surgically addressed and balance the negative feedback. The response depends on several factors, can be summarized into injury-related and patients-related factors. Factors related to the injury. 1. Type. 2. Severity. 3. The duration of the injury. Number 4 is the patient-related factors. A. Patient's genetic makeup. B. Age of the patient. C. The health status of the patient before the injury. Let's take an example of each factor. The type of injury: burn patient would have severe response more than a patient with a cut wound. The severity: third-degree burn would have more severe response than first-degree burn. The duration: 2 hours. Shock would have severe response more than a patient in shock for 30 minutes, taking in account the same severity and type. So resuscitation, surgical intervention and critical care can return the severely injured patient to a situation in which homeostasis becomes possible once again. Stress-free perioperative care helps to preserve homeostasis following elective surgery, and these medical and surgical intervention could make severely injured patient get back to normal physiologic homeostasis by decreasing the effect of the injury that would balance the negative feedback and prevent further complications. The manipulation of the patient's related factors to decrease the response of injury, such as the patient's genetic makeup and the age, impossible. The medical intervention can assist to optimize the patient's health status, for example, diabetic patient after injury. Again, why the concept of normal homeostasis does not apply to severely injured patients. Because these changes may be helpful in the short term and can be harmful in the long term, especially to the severely injured patient who would otherwise not have survived without medical intervention. Each step of the homeostasis have a negative feedback. The severity of this feedback is proportionally related to the severity of the basic response. It can be severe enough to affect the body negatively and lead to death. Let's have examples. Let's explain the response and its negative feedback on the following graph line. The x-axis line represents the time. The y-axis line represents the response. The response has two phases, pro-response above the pink line, and negative feedback or anti-response below the pink line. For instance, we have an injury at 0 time. In cases of mild to moderate injury with appropriate support, the pro-response and anti-response will be mild to moderate. The purpose of homeostasis will be successfully achieved. The result will be a rapid recovery. Severe injury that get by the body's abilities to compensate, for example, complete transection of the spinal cord. The body will get early multi-organ failure and early death. Cases of moderate injuries, or haven't had appropriate resuscitation, or have had complications like sepsis after injury, and others. They would have a persistent pro-response that a persistent anti-response would counteract. The homeostasis cannot be achieved, resulting in incomplete recovery. Let's delve deeper into the response mechanism and how it works. All the mechanisms described are for academic purposes. However, in reality, the mechanisms of systemic response to injury occurring in the body are interconnected, overlapping, and affect each other, both positively and negatively. In the next slides we'll talk about detector and how it transmits the information to the processor and how the processor takes over and stimulates the effector. Starting with the detector will take us through the sequences until we reach the target, the whole body. The main purpose of the response is to return the body to its normal status. This is done through the process to provide the traumatized part of the body with the nutrients, postpone anabolism, and enhance the immunity. Generally there are two types of detectors. At the site of injury, or detector of the consequences or effect of the trauma. At the site of injury. 1. Immunity through damage-associated molecular pattern. 2. Peripheral nerves detect the pain. Detector of the consequences of the trauma. 1. The effect of shock on aldosterone. 2. Chemoreceptors detect the changes of the oxygen, carbon dioxide, and blood pH. 3. Baroreceptors detects the changes in the blood pressure and osmolality. The next animation will explain the damage-associated molecular pattern.
We'll take a brief about immune system before we start. Cellular-wise, we have two types of immunity: innate immunity and adaptive immunity. Examples of innate immunity cells: macrophage, neutrophil. Examples of adaptive immunity cells: T helper 1, T helper 2, B lymphocytes. Let's zoom into the blood vessel and watch how the immunity detect the injury. Damage-associated molecular pattern, DAMP. Once the normal cell is exposed to injury or necrosis, the cell membrane shatters. Then the organelles and substances are freely circulated in the blood. These organelles' structures are proteins, antigens, damage-associated molecular pattern. Innate immunity cells have receptors, so-called pattern recognition receptors, PRR. Once those receptors detect the organelles such as mitochondria or heat shock proteins, they activate the immunity cell to release cytokines and interleukins like interleukin 1, interleukin 2, interleukin 6, and tumor necrosis factor alpha and beta. Hence, the immunity system is considered as detector of the tumor and processor. At the same time, the effectors here are cytokines, interleukins, and other immunity cells. Mediators. The released cytokines activate adaptive immunity cells, lymphocytes. We'll take example here, T lymphocytes, helper 1 and 2. Here it is important to mention that if trauma is severe, the innate immunity cells will activate T helper 2 rather than T helper 1. We'll see the differences later. A query may arise at this point. Daily, thousands, if not millions of cells perish. Why doesn't our immune system react to these dead cells? This helps us comprehend programmed cell death, where the cells receive intracellular or extracellular signals for cell death. A cellular agent breaks down proteins and other organelles. The nucleolus compacts, and the entire cell reduces in size. Then it's engulfed by macrophages. While proteins are degraded, they can't be recognized by the immune system, resulting in no inflammation. As mentioned earlier, cytokines and interleukins are effectors of the immunity system. After they're released in the blood, they affect the whole body. They increase the basal metabolic rate particularly, and tumor necrosis factor. Interleukin 1 and 2 raise the temperature. And interleukin 6 induce the liver to produce C-reactive protein.
As illustrated in the preceding slides, each component detector, processor, and effector exhibits a regulatory mechanism or form of inhibition. Subsequent animations will elucidate the regulatory elements of the immune system and detail how homeostatic processes exert control over immune responses. Regulation of immune responses can be exerted through intrinsic mechanisms within the immune system or by extrinsic factors originating from other biological systems.
Immunity has a significant interaction with the nervous system. When immune cells are activated by an injury, they produce interleukins and cytokines. The afferent pathway involves the parasympathetic nervous system, which when activated, triggers a reflex through the sympathetic nerves leading to the release of norepinephrine. Norepinephrine exerts a pro-activating effect on immune cells. Conversely, the hypothalamus can have a negative impact by stimulating the anterior pituitary gland to secrete ACTH, which then prompts the adrenal cortex to produce cortisol. Another adverse pathway occurs through the parasympathetic efferent nerves that release acetylcholine. Both cortisol and acetylcholine serve as antagonists, anti-inflammatory agents, to immune cells, inhibiting or reducing the production and actions of interleukins and cytokines.
Therefore, the inflammation initially driven by pro-inflammatory cytokines, such as interleukin 1, interleukin 2, interleukin 6, interleukin 8, and tumor necrosis factor alpha, increases in plasma levels of cytokine antagonists, anti-inflammatory, or soluble receptors, including interleukin 1 receptor antagonist, tumor necrosis factor soluble receptors 55 and 75, transforming growth factor beta, interleukin 10, and interleukin 13, occur quickly after these pro-inflammatory events. There are other role players from different systems, as we saw in the earlier animations. They function as either antagonists like cortisol and acetylcholine or agonists like adrenaline. Systemic inflammatory response syndrome, SIRS, is diagnosed when the traumatized patient exhibits signs of significant inflammation. It is beneficial in short period of time. If prolonged or excessive, may evolve into a counter-inflammatory response syndrome, CARS. Let's explain it in the following graph line. Again, the x-axis line represents the time. The y-axis line represents the response. Above the pink line is the pro-inflammatory response. Below the pink line is the anti-inflammatory response. Mild to moderate trauma result in an acceptable surge up of pro-inflammatory agents and response. It will countered by same amplitude of anti-inflammation. Both responses fade out, and recovery will be achieved without complications. On the other hand, if there is severe trauma, both responses are huge, resulting in systemic inflammatory response syndrome. That manifested by high plasma levels of pro-cytokines, fever, capillary leak, and ultimately organ dysfunction. The SIRS, countered by counter-anti-inflammatory response syndrome. That manifested by high plasma level of anti-inflammatory cytokines, deterioration of immunity in picture of attenuated innate immunity, antigen detection function, attenuated lymphocytes function, and immunity cells apoptosis. Let's see the stages, in the next animation, at the cellular and immunity effectors level.
In the upcoming animation, we will observe how an increase in pro-inflammatory and anti-inflammatory responses can exceed the capability of the immune system to function effectively, leading to a breakdown of overall immunity. Initially, the response starts with a few pro-inflammatory cytokines that are balanced by anti-inflammatory ones in the case of mild to moderate injury. The T helper 1, CD4+ lymphocytes are the dominant type of cells. The immunity is cellular. However, if complications arise, both pro-inflammatory and anti-inflammatory cytokines increase. At this point, the immune system does not activate its cellular immunity, which is normally triggered by T helper 1 lymphocytes. Instead, the immune response shifts towards antibody-mediated immunity involving T helper 2 CD8+ cells. This scenario corresponds to severe trauma. This shift results in less effective immunity, making the patient vulnerable to infections and additional complications. If the situation worsens further, the entire immune system can collapse, leading to end organ damage and potentially death.
This table shows functions of some interleukins. Eicosanoids are local hormones from 20 carbon fats, crucial for inflammation, blood clotting, and more. They mainly come from arachidonic acid, AA, producing pro-inflammatory compounds. EPA and DHA, omega-3s, compete with AA, leading to fewer pro-inflammatory eicosanoids and instead forming specialized anti-inflammatory resolvins and protectins, shifting the body towards reduced inflammation. While our bodies can produce some EPA and DHA from the plant-based omega-3 alpha-linolenic acid, ALA, this conversion is generally not enough to significantly reduce inflammation in cases of a systemic response to injury. Infection is defined as identifiable invasion of microorganism. Systemic inflammatory response syndrome is presence of two of the following: temperature, more than 38 or less than 36 degrees centigrade. Heart rate more than 90 beats per minute. Respiratory rate more than 20 cycles per minute or PCO2 less than 32 mm mercury. White blood cells more than 12,000 or less than 4,000 with 10% or more band forms. Sepsis is infection and SIRS. Once it associate with organ dysfunction, it is severe sepsis. Presence of cardiovascular instability with sepsis, it is septic shock. The second detector is the peripheral nerves. The next animation will demonstrate the neuroendocrine response to trauma.
When there is a trauma, the nerve endings detect the pain. The impulses are transmitted through the spinal cord tracts up to the hypothalamus. The hypothalamus releases the corticotropic releasing hormone CRH and growth hormone releasing hormone GHR. on the anterior lobe of the pituitary gland. The pituitary gland releases the adrenotropic hormone ACTH and growth hormone GH. The ACTH stimulates the adrenal cortex to release cortisol. The hypothalamus, simultaneous to the stimulation of the pituitary, stimulates the sympathetic nervous system. The sympathetic releases noradrenaline. Noradrenaline stimulates the adrenal medulla to release adrenaline. The noradrenaline also stimulates the alpha pancreatic cells to release glucagon, cortisol, adrenaline, noradrenaline, growth hormone, and glucagon transmitted in the blood to the target organs. All hormones except glucagon activate muscles proteolysis to produce amino acids that to be used by the liver for gluconeogenesis. The hormones activate the gluconeogenesis in the liver, and the glucagon started the glycogen analysis. The glucose produced by glycogenolysis is only 80 grams. The hormones increase the lipolysis in the adipose tissues.
The second is the detection of the effect of injury-like effect of shock on renin-angiotensin axis.
Blood loss after trauma leads to hypovolemic shock. Low blood flow to the kidneys will result in diminished perfusion of the kidney's functional unit, the nephron. The afferent arterioles of Bowman's capsule have a juxtaglomerular apparatus, which is where renin is produced and released. However, renin release depends on the macula densa, which are cells sensitive to sodium. Low sodium levels in the distal convoluted tubules due to low perfusion and low filtration of sodium will stimulate the macula densa, which in turn stimulates the juxtaglomerular apparatus to release renin. The angiotensin formed in the liver will be converted by renin to angiotensin 1. Angiotensin 1 will be converted by angiotensin converting enzyme ACE in the lung to angiotensin 2. Angiotensin 2 is a potent vasoconstrictor and stimulates the adrenal cortex to release aldosterone. Aldosterone will increase the reabsorption of sodium and will increase the vascular tone.
The metabolism after trauma has two phases. Ebb phase. Flow phase. The ebb phase is the shock phase. After resuscitation, the body goes through the catabolic flow phase, and then recovery will start in the anabolic flow phase. Depending on the severity of the injury, each phase will have a different duration and different physiological effects and roles. At the same time, each phase is controlled by specific hormones. The duration of the ebb phase is hours while the patient is still in shock. The body tries to preserve its lost elements of life, such as blood. So, it decreases the basal metabolic rate, decreases the temperature, and decreases oxygen consumption. It increases the cardiac output by increasing the heart rate, while there is vasoconstriction. At this time, the innate immunity has started releasing interleukin-6, which increases C-reactive protein from the liver. The role of this phase is just to maintain blood volume. The hormones responsible for this phase are catecholamines, cortisol, and aldosterone. The catabolic flow phase is a crucial time when the body needs support and continuous monitoring, as it is a period prone to complications. This phase typically lasts from 3 to 10 days. Physiologically, the body will increase its basal metabolic rate and temperature, leading to a high demand for oxygen. To maintain high energy, which is the primary role of this phase, the body requires glucose. This glucose can only be provided through gluconeogenesis, fueled by amino acids produced via muscle proteolysis. This process results in a negative nitrogen balance. The hormones responsible for this phase are glucagon, cortisol, and catecholamines. While insulin levels are very high at this stage, the aforementioned hormones induce resistance to its action, thus maintaining elevated glucose levels in the blood. The anabolic flow phase represents the stage where the body aims to restore all lost tissues. This phase can last up to 60 days. Its primary role is to achieve a positive nitrogen balance, which indicates anabolism and the cessation of proteolysis. The hormone responsible for this phase is growth hormone, particularly in the presence of insulin-like growth factor, IGF-1. Indeed, insulin-like growth factor is crucial for the anabolic effect of growth hormone, as growth hormone acts as a catabolic hormone in the absence of insulin-like growth factor. Insulin-like growth factor is primarily manufactured in the liver, provided there is an absence of catabolic factors from the immune and endocrine systems.
During the flow catabolic phase, the demand for glucose at an injury site often exceeds the immediate supply from the liver's stored glucose, which only provides about 80 mg. A significant portion of the body's glucose is stored as glycogen in muscle tissue. However, since muscles lack glucose 6-phosphatase, this stored glucose cannot be directly released into the bloodstream as free glucose. Consequently, gluconeogenesis is initiated primarily in response to certain cytokines, especially tumor necrosis factor or TNF, and stress hormones like cortisol, catecholamines, and active thyroxine. These biosubstances trigger muscle proteolysis, breaking down muscle protein into amino acids. Under the continued influence of stress hormones, the liver increases its uptake of these amino acids. Through gluconeogenesis, these amino acids are then converted into glucose. This newly synthesized glucose is then mobilized to the injury site and to obligate glucose users, particularly the brain and muscles. Despite the elevated insulin levels during this phase, the presence of high insulin resistance compels the body to seek an alternative energy source, namely ketone bodies produced through ketogenesis. Under the influence of cortisol, cytokines, adrenaline, noradrenaline, glucagon, and growth hormone, lipolysis of subcutaneous adipose tissue produces free fatty acids. Coupled with persistent insulin resistance and the effects of stress hormones, the mitochondria of hepatocytes convert these free fatty acids into ketones. These ketones are then used as an alternative for glucose, mainly by cardiac muscle, skeletal muscles, and the brain. Stress hormones is stimulator, while effective insulin is inhibitor for both gluconeogenesis and ketogenesis.
We must now gather all the basic information mentioned above and apply it to the patient. We need to summarize the clinical signs and how to address them so that we can intervene appropriately. We must understand that the duration of each stage depends on the severity of the initial injury. At the same time, the variability of response per patient. Proper intervention means mitigating and treating the complications of each stage to bring the patient to safety. The main features of each phase will be counted here. Then we'll explore the clinical signs of each phase. In the ebb phase: 1. Hemodynamic instability. 2. Hypometabolism. The catabolic flow phase: 1. Hypermetabolism. 2. Catabolism. 3. Insulin resistance. 4. Systemic response to injury. While the anabolic flow phase: characterized by tissues rebuilding and anabolism. Ebb phase clinical features and intervention. Hemodynamic instability, shock. The patient will have low blood pressure, tachycardia, and decreased tissue perfusion, cool, clammy skin and delayed capillary refill. The intervention should focus on ATLS protocol. Secure airway and breathing. Aggressive fluid resuscitation, with IV fluids. Blood product transfusion, for significant hemorrhage. Source control, stop bleeding by surgery or embolization. The second clinical feature of ebb phase is hypometabolism, which manifested by hypothermia, reduced oxygen consumption, and potential lactic acidosis. The intervention should be started during resuscitation by giving warm IV fluids and covering the patient. Oxygenation and ventilation, ensure adequate oxygen delivery. Optimize perfusion, by address the shock to improve tissue oxygenation and reduce acidosis. Painkiller, to reduce the response. And sedation, for agitated or ventilated patients. The flow catabolic phase characterized by hypermetabolism. Clinically, the patient will have fever, significantly increased resting energy expenditure, increased oxygen consumption and CO2 production, high cardiac output and respiratory rate. The right intervention is nutritional support, early enteral feeding preferred, parenteral if enteral is contraindicated or insufficient. Adequate calorie and protein delivery, based on estimated needs according to severity of injury and the patient general condition. The second characteristic of flow catabolic phase is catabolism. The patient will have rapid weight loss, visible muscle wasting, negative nitrogen balance, which means increased urinary nitrogen excretion in comparison to protein intake. And it is calculated by each gram of nitrogen secreted in the urine indicates breakdown of 6 gram of protein. The glutamine and alanine are the most commonly used amino acids for gluconeogenesis. The right intervention is adequate ventilatory support, to meet the required respiratory function, as respiratory muscles would be wasted in gluconeogenesis. The third characteristic of flow catabolic phase is insulin resistance and hyperglycemia, persistently elevated blood glucose levels, and lipolysis. The right intervention is strict glycemic control, insulin therapy to maintain blood glucose in target range, 140 to 180 mg per deciliter. Avoid hypoglycemia and hyperglycemia. Essential fatty acid supplementation. In severe trauma or sepsis cases, while there are high ketone bodies and high glucose, the presence of stress hormones prevent the use of these nutrients. So, the systemic response to injury will not achieve the purpose as mentioned earlier, and the best intervention is treating the underlying cause. The fourth characteristic of flow catabolic phase is systemic inflammatory response syndrome, SIRS. Manifested by sustained fever, tachycardia, tachypnea, leukocytosis, elevated acute phase reactants, tissue edema. In addition to the previous steps, the right intervention is infection control, early diagnosis and treatment of infections, source control, drainage of abscesses, debridement of necrotic tissue, supportive care, organ support as needed, ventilators, dialysis. Omega-3 administration might regulate the immunity. The patient weight might increase due to fluid retention and edema. The characteristics of flow anabolic phase are gradual weight gain, positive nitrogen balance, restoration of muscle mass and function. The intervention is continued adequate nutrition, crucial for sustained anabolism. Aggressive physical therapy and rehabilitation, essential for functional recovery. Psychological support, address potential post-trauma stress disorder and depression. The negative effect of the hormones can be summarized in exhaustion of all hormone sources and the target organs. Thank you very much for your attention.